We have an incredible speaker who's going to kind of tie up some of these things we've kind of introduced, including and some of the things we'll be talking about later today: preeclampsia, depression, and then using telemedicine in the postpartum period. Not something that most people think about. I always enjoy delivering quads or something like that. There's usually like 4 neonatal teams and anesthesia, and you can't even get in to do the C-section. As soon as the babies are out, you're left, and there's like crickets and a CRNA, and that's it, okay? So we kind of neglect postpartum, but postpartum period is probably one of the most important health determinants for outcomes. And if we're going to make differences in mortality that you'll hear about a little bit later, that's where I think we got some real wheat that we can harvest. But our next speaker is Dr. Kara Hoppe. She is currently an assistant professor at the University of Wisconsin in Madison, Wisconsin. She did her undergrad at Winona State in Minnesota, Midwestern for her osteopathic degree. Went to the other UW. For those of you who like football, there's only 2 places in the U.S. where you can go to a football game by boat. One, of course, is the famous Vol Navy. The other one is the University of Washington. So she did her OBGYN residency there and her fellowship in maternal fetal medicine. She has since completed a master's in clinical research and is working now on her PhD for clinical research. She has become the authoritative figure on postpartum telemedicine. And it dovetails nicely into what Stork is trying to do and increase accessibility to the rural areas, including postpartum. So I'm going to turn it over to Kara. Here.
Thank you. Thank you for the kind invitation and allowing me to be here today and share some of the work we've been doing. After a heavy morning, hopefully it'll lighten it up a little bit, but I'm open, for any questions or ideas moving forward. I do not have any disclosures. So really the objectives I hope to cover are to review and focus mostly on postpartum hypertension. This is applicable to many areas of postpartum, but we'll focus on this and kind of carry that through. And what we know about that, why is it postpartum specifically important, and postpartum readmissions and potential strategies to avoid those readmissions, innovative strategies and experience with telehealth and remote patient monitoring for postpartum hypertension. So just starting with a little bit of what we know. So physiologic changes in pregnancy really have been investigated, more intensely before delivery, but the postpartum period is wide open. So this was approximately 60 patients in the 1980s that they followed throughout pregnancy, and you can see the top being systolic blood pressures, the bottom being diastolic blood pressures, that blood pressures naturally go down when you become pregnant, and they stay down until about the 3rd trimester, where they then start increasing. And you can see oftentimes at the very end of pregnancy, the blood pressures return to baseline from beginning pregnancy. And then all we have is one data point, 4 to 6 weeks postpartum. And this is what's in the textbooks, and so not much about postpartum hypertension. There's been a little bit of work in the physiologic changes postpartum. So primarily that work has been done by Walters in the 80s. They studied about 140 normotensive women and about 70 hypertensive women postpartum, keeping them in the hospital about a week, checking their blood pressure, seeing what they would do. So normotensive women had both systolic and diastolic raises in their blood pressure. Systolic about 6 millimeters of mercury and 4 on the diastolic blood pressures. And they would rise for the first 4 days after delivery, and they found 12% of women had diastolic blood pressures that achieved over 100 millimeters of mercury. Again, normal women, normal postpartum physiology. So then women with preeclampsia, they found that there was a decrease in blood pressures within those first 48 hours of delivery, but then the blood pressures would increase again between days 3 and 6 postpartum. Now, what did that look like? So there's one figure on day 5, the top being systolic blood pressures, the bottom being diastolic blood pressures. And you can see on the y-axis the percentage of patients and then the values of their blood pressures. And their conclusion was that on day 5 postpartum, that there was commonly blood pressures that exceeded 150 over 100, 150 systolic and over 100 diastolic. That's what we've got. So furthermore, in 2010, there was a study done by Partum that wanted to determine the number of weeks that postpartum blood pressures would take to normalize. It was a retrospective cohort study. of women with gestational hypertension and preeclampsia, and they studied around 60 women and found that if blood pressures were going to normalize, it took about 5 weeks plus or minus 3 weeks, but 19 to 20% of them remained hypertensive at 6 months, and then 3 of them had a diagnosis of secondary hypertension. So what values should we worry about or consider treating postpartum? So in 2015, there was a big document put out by ACOG talking about all aspects of hypertension in pregnancy, and the current ACOG guidelines are really based on expert opinion rather than experimental data, and they recommend treating postpartum hypertension if you have systolics greater than or equal to 150 or diastolics greater than or equal to 100. So I searched and searched and searched to figure out where those recommendations came from, and this is the best I could find. So there was an opinion piece put out in 2002, and these are just little excerpts from that opinion piece, and it says, the observation that most fits, i.e. seizures, are unheralded by warning signs and makes postpartum hypertension all the more worrying. The aim of treatment is to prevent severe hypertension and sequelae, so cerebral hemorrhage, very occasionally eclampsia, and it says, however, in the absence of such data, we have to rely on our clinical experience. This would suggest that the risks are very low, particularly after third day postpartum. So they're really talking about, postpartum symptoms and seizures and risks of that. And they go on to say that antihypertensive drugs should be given if blood pressure exceeds the 150 over 100 threshold in the first 4 days of the puerperum. While it's acknowledged that this is a chosen threshold is arbitrary, it may be somewhat low. It should be remembered that blood pressure might continue to rise further in the days to come. Again, based on the data I just showed you, which is really minimal amounts. Overtreatment with a view to discharging women who are otherwise well and reviewing them in 1 to 2 weeks is preferable than unnecessarily keeping them in the ward. I just think it's important to know why we do and where it comes from. So why is postpartum hypertension important? These are just a few things I pulled off the internet and what I wish I had known. 75% of maternal deaths are associated with preeclampsia, and they actually occur after delivery. And furthermore, we all know that hypertension is increasingly common in our pregnant patients. So about 10% of pregnancies are quoted to be affected by hypertension in the United States. We have a bit more of a problem in Wisconsin, and I would imagine a lot of other states do, and the data is behind. But our current data is about 1 in 5 Wisconsin women have hypertension that affect their pregnancy. Postpartum has been rather understudied, if I haven't convinced you by now, but the exact incidence is really unknown. It's thought that up to half the women eventually diagnosed with postpartum preeclampsia were not diagnosed in the before delivery period or the immediate postpartum period, but 75% of deaths secondary to gestational hypertensive disorders are occurring after birth, with 41% in one study occurring more than 48 hours postpartum. And regarding a public health impact, so we'll be hearing more about this soon, but maternal mortality is on the rise. So it's about 26.4 per 100,000 deliveries in the United States. And you can see in this figure over here, it's small, you don't need to see the details, but you can see the incidence here and the years over here from 1990 up to 2015. USA is way up here compared to the other developing countries. And so there's a lot of focus on our country right now, and why is that happening? So 2 out of 3 pregnancy-related maternal deaths occur postpartum, and they're related to high blood pressure and cardiovascular disorders. And then women with hypertension during pregnancy have a 3-fold increase of long-term cardiovascular mortality. So none of this stops at delivery, not even the immediate postpartum period, but there's actually risk factors that we should be paying attention to throughout the woman's lifespan. On another note, U.S. hospital readmissions are on the rise. So this is data from CLAP published in 2016 looking at readmissions from California, Florida, and New York. There's over 600,000 deliveries in here, 6 million deliveries and 100,000 readmissions in their data. And you can see that the overall readmission rate here on the y-axis, the years over here, the black line is the average overall, readmission rates are now exceeding 2% in many states. And that's all-cause readmissions. So when we look at what's causing them, again, percent of readmissions here on the y-axis, and these are all reasons why people are being readmitted. And I really just wanted you to see the number one reason is hypertension, followed by wound infection and other psychiatric problems. And then when are these readmissions happening? So I put a box around this early first 10-day period of time because that's when they're happening. But what I want you to see is that the green line here is hypertension, and most of those readmissions are happening on day 3 compared to the all-cause other reasons, like wound infection and psychiatric disease happening later, like around 7 days to 10 days. So what is the cost of a postpartum readmission? So this is data from Mogos, again, really recent, 2013 to 14 data, 6 million delivery hospitalizations, again, 10% or so are associated with hypertension. But what they found was that the readmission rates for hypertension range from 2.5 to 4.6, 4.6 being more higher tertiary care centers taking care of sicker women. But compared with the normotensive pregnancies, hypertension-related pregnancies resulted in an excess of 404,000 hospital days and care costs of over $731 million. And what does ACOG say about keeping the women in the hospital, following them up, and in that postpartum period? So they say that women with gestational hypertension, preeclampsia, or superimposed preeclampsia should be at least considered to be followed in the hospital for 72 hours or some alternative that would be consistent with following them in the hospital. And then postpartum, they should be seen 7 to 10 days after delivery or earlier in women with symptoms. And a lot of these women don't have symptoms, and so they're not coming to care even at 7 to 10 days postpartum. Also, I wanted to highlight that chronic hypertension is not listed there unless they have preeclampsia on top of their chronic hypertension. So what strategies do we have to reduce these avoidable maternal readmissions? So at discharge, these are from the American Hospital Association. They say implement comprehensive discharge planning, educate patients and caregivers and teach back methods on what they're teaching them about, and schedule and prepare follow-up appointments. And I'm not sure how things work here, but my hospital is like we are not in charge of scheduling follow-up appointments for people, and therefore it's really hard for them to come back because it's on them to schedule their appointments. So simple things that we could do, like scheduling their appointments, may help get them back into care. So at post-discharge, they suggest doing things like promoting self-management, conducting home visits, and follow up with the patient via telephone. And these are a bit outdated, so I think that there's a lot more we could do with this. So I was starting my first faculty job, and I was like, what am I going to focus on? And seeing that hypertension was a problem, and readmissions were really high at our hospital, like approaching 5% for hypertension, and I was like, we've got to do better. So can we do better in general? And that's where I'm going to take the talk for the rest of this time. So I thought about how we could do that, and one thing that came to me was home blood pressure monitoring. So it's demonstrated to be cost-effective in treating non-obstetrical patients, and preliminary research suggested that home blood pressure monitoring in pregnancy could also be effective. A lot of feasibility studies mostly focused on before delivery. So telemedicine in general, this is a little bit of older side as well, but just to kind of like start bringing up some ideas, and I think this audience probably doesn't need to know a lot of this, but in general, impact of telemedicine. So a lot of healthcare leaders are developing and implementing telemedicine technology. A lot of healthcare outcomes are better when there is telehealth involved. Telemedicine programs also are considering remote monitoring, things like following their glucoses at home or their blood pressures, or there's a lot of information out there in heart failure patients and preventing readmission and things like that. A lot of healthcare leaders say that improving the quality of care was a priority to them, and a reason why they implemented telemedicine. And then Americans would be willing to have a video visit with the doctor. It's really appealing to patients. But in general, benefits of telemedicine, in my mind, and I think in many minds, is that it increases access to healthcare, it can reduce costs, it can improve healthcare outcomes, and there's fewer in-person consultations. Postpartum being a place where a lot of people don't want to come to the doctor and they've got other priorities like their new baby. And this is just, a quick refresher that telehealth is a broad term, and it can include, things such as live video conferencing, meaning like your patient is over here on a camera and we're over here on a camera and we can see each other together. But there's some store and forward where you're taking a video capture of an encounter and somebody reviews it later. There's remote patient monitoring, which is specifically using electronic tools to review their health in a different location, but you're not actually video chatting or talking about it. There may be other ways you give them feedback, like an email or a text or something. And then there's mobile health, which is more healthcare and public health information that is provided through mobile devices, such as like targeted text or educational information. So home blood pressure monitoring, if you're going to get into that and you're going to try to do some remote type monitoring or even combine that with telemedicine or telehealth, it's really important to provide them instruction and train the patients on how to do that and standardize that process at home. So it includes a rest period prior to measuring their blood pressures, that they actually have the appropriate position and cuff size for taking their measurements, and then also avoiding factors that could influence their blood pressure like stress, lack of sleep, or even coffee or caffeine. This is a large white paper that was put out in 2017 by Welton, and it's available in details. What it goes through is all techniques for home blood pressure monitoring. This is just an excerpt that I'm not going to go through, but you'll have if you're interested, just on how you train patients, the devices you should use, and how they should be taking those blood pressures at home. It also goes through like ambulatory blood pressure monitoring, how clinic blood pressures, home blood pressures, ambulatory blood pressures all vary. So it's a really nice resource document. And then when I started looking into this, really, to be honest, I wanted to create my own platform, and that's a really challenging and expensive thing to do. And I had the opportunity to work with a company. It's called Residio. It used to be Honeywell. But what I was able to do in my preliminary work was use their equipment. And so it's a combination of this Genesis Touch tablet. It's basically a Verizon tablet or an iPad, for lack of better terms, but it's connected to the Verizon phone line, and you can also use it on Wi-Fi. It's set up specifically for home monitoring. You can do video monitoring, and all the peripherals are connected through it. So it walks you through, like, you push a button and it says take your blood pressure, take your weight, take your oxygen saturation. It also asks them questions about how they're feeling every day, if they've had to access health care, if they have any concerning symptoms of preeclampsia. And then through that same monitor, they can video conference in a telehealth live way with a nurse or whatever healthcare providers on the other end. And then all of that data goes to our nurse platform or provider platform, but primarily I have nurses monitoring my platform, and it brings in all these vitals and all this information from all the patients, and you can color code it based on, thresholds of blood pressures, et cetera. They can document in there. And so all of that together makes a nice platform for this home monitoring program, capable of doing telehealth and telemedicine visits as well as remote patient monitoring. So it's kind of what it looks like. These are our peripheral devices, blood pressure cuff scale, O2 sensor. They have other devices and, like for following asthma and diabetes, glucose monitors, et cetera. This is what that tablet looks like. And you can see here through all these things, we can have video conferencing. And then here's what it would look like for someone looking through the daily data we get. So the next part I just really wanted to talk about was some innovative strategies, research, and experience with telehealth and remote patient monitoring, specifically for postpartum hypertension, but really the sky's the limit of what you could do. So the first work we did was just some feasibility. We really wanted to establish whether telehealth with remote patient monitoring for monitoring and treatment of postpartum hypertension in women that would be at risk of sustained development of severe hypertension could be accomplished within those 6 weeks postpartum. The primary outcomes we were really looking at was, could we recruit people, could we retain people, and we also wanted to collect some information about the incidence of severe hypertension after discharge, how satisfied patients were, and what would our readmission rates look like. And to do this, we would identify women on their primary postpartum admission. We would make sure that they had some sort of diagnosis of hypertension. We take all comers, whether it's chronic hypertension or somebody who has HELLP syndrome or really bad preeclampsia. And then we would ask them, we would tell them about our program, ask them if they were interested. And then prior to discharge, again, wanting to make this simple, accessible, and easy for patients, we would bring them all the equipment. We would teach them how to do their blood pressures and how to take care of themselves at home, and get them that in their room before they left. And then once they're home, they just plug it in and they start submitting their daily vital signs. We scheduled a visit with the telehealth team at 2 days postpartum and then daily as needed. And then the nurses, like I said, would interact them commonly multiple times a day or again as needed. And then our end of study clinic visit was just our 6-week postpartum visit. Everyone was instructed to go to that visit. We also conducted a postpartum satisfaction survey as well. But in the meantime, nobody had to go to clinic for any of their blood pressure follow-up, unless we were worried about them. So we quickly learned that if we were going to do this, we needed a standard way of providing this care. We created some treatment algorithms. They're here. They're published algorithms, so you could use them if you really wanted to. But we created them separately, one for people who are on antihypertensive medications already, like how do you titrate them up and titrate them down? What medications might you choose? And we use a lot of heart rate to guide that. And I won't get into that a lot, but the physiologic changes of hypertension are probably different for different people, and different meds might work better than others. And then we also have a separate one for people that, the first one was people not on meds, and then people who are on meds. Again, our goal is to keep them normotensive, and also when they're showing signs that their blood pressures are better, then we can help them get off the medications when it's appropriate for them. So it didn't take us long to do this. We spent March to July of 2017. About 20% of our deliveries have hypertension. About half of them, just through the grapevines of provider mouths, were willing to be approached. We had a fancy clipboard, and as we were able, we would approach these patients. We ended up consenting half the people that were willing to be approached, and we thought that that was a good sign. So this is just our feasibility data, and really just to kind of focus on a few things. We had our mean age of about 30. Many of the women were married in our group. We have a very Caucasian population, and so it was highly Caucasian women. The gestational age was about 37 weeks, equal amounts of vaginal and C-section. We took care of all types of hypertension, about 10% chronic, 30% gestational, about 60% preeclampsia. Despite the recommendations to maybe not use NSAIDs postpartum, the majority of our patients received NSAIDs for pain management. They all went home about day 3, plus or minus 1 day. Again, guidelines suggest we should keep them in the hospital longer. They all had blood pressure control when they left, and about 40% of our women were on a blood pressure medication. So the outcomes that we we're really looking at, some of those secondary outcomes, and I think is really insightful, is that the total amount of participants who had severe hypertension after discharge was almost 20% of our women, meaning greater than 160 over 110. And that was happening on day 5, plus or minus about 2 days. And then furthermore, patients who had, the threshold where ACOG is suggesting 150 over 100 for treatment was 50% of our patients. So despite going home on meds, it wasn't protective in a lot of those patients to not have really high blood pressures. And so in total, about 60% of patients required blood pressure medications in the postpartum, and our program specifically initiated a new med on about 20% of patients and increased the medication dosage on about 25% of patients. We still sent people in for evaluation if we were worried about them, but we had 0 hospital readmissions. Now, granted, this is a small data set and a feasibility study, and so we found that patients were overall very or extremely satisfied with their experience. And we also asked a question about what extent would you prefer using telehealth versus clinic amongst these postpartum women who have this hypertension problem. And, as you can see here, the majority of people would rather use telehealth than go to clinic. So just in summary, we had about 55 patients. We thought that our consenting and was good, about 50% of those patients. We also retained 95% of them through 6 weeks postpartum. We didn't have any hospital readmissions. People were really satisfied. And we also found that there are a lot of patients who have blood pressure problems when they leave the hospital. And it's happening after day 3 and before day 7 to 10. So in conclusion, we demonstrated that we thought our program was feasible, that telehealth monitoring for postpartum hypertension was again feasible. We observed that there were some important temporal trends in the natural history of postpartum hypertension, which really hasn't been talked about in a larger study or really this long, and thought that that would be important to guide larger clinical trials. And then we thought that this was a promising outpatient treatment strategy for people who have postpartum hypertension to maybe reduce readmissions and also decrease the maternal morbidities. But we thought we needed to answer that in a bigger study. So preventing readmission secondary to hypertension was what we moved on to next. And the objective of our work was really to determine if we could effectively reduce the 42-day readmission rate in women using our intervention compared to standard of care. So a very similar flow diagram of our trial schema. This took us about a year to do, and we had 4,700 deliveries with about 1,000 of them having hypertension. Again, their primary postpartum admission. We consented people here only to participate in the home blood pressure monitoring intervention. At this point, the hospital was pretty convinced this was a good idea, and they weren't willing to randomize people to no treatment if they wanted to participate in this program. So we had a concurrent enrolled standard control arm. So at discharge, again, they received their equipment and training, and all other women just had standard discharge instructions about warning signs of preeclampsia, and were told to follow up as standard of care. And then, as we already mentioned, once it went home, our intervention arm did daily vital sign reporting. They had a follow-up visit through telehealth. And then the recommended outpatient follow-up was 7 to 10 days in their clinic for the control arm. And at our end of study visit was just a standard 6-week postpartum visit. Again, surveys were sent to the people participating in the telemedicine intervention. We had 214 people in each arm. So this is a big table with just summary data, just so you can have it. But what I wanted to highlight was just there was no difference in our arms about the type of hypertension we took care of, similar kind of strata from the feasibility work of types of hypertension. Again, our population is very Caucasian. It's not different than the feasibility work. And the only difference we really had in our groups was in the insurance status, so more women on private insurance elected for the telehealth intervention. And then we wanted to look at the inpatient clinical characteristics among people using telehealth with remote patient monitoring versus our standard care for postpartum women. And within these characteristics, we did see that there were more people in our telehealth intervention who had C-section, and that there was no difference in the amount of NSAID used postpartum for pain control, and all blood pressures, the maximums and discharge blood pressures were similar in our two groups. We had a difference in our telehealth intervention with more people being discharged with blood pressure medication. And though it's statistically different, the postpartum day of discharge is probably not clinically different. They're about 3 days, but when you have decimals, it looks different. So they're both kept about 3 days. So table 3 really is the outpatient outcomes among our telehealth users with remote patient monitoring versus the standard outpatient care arm. And our outcome was really powered to look at hospital readmission. And so in our telehealth intervention arm, we had 1 hospital readmission related to hypertension, and we had 8 in our standard outpatient control arm. So that's 0.5% versus 3.7%. The standard 3.7% incidence was similar to our baseline readmission rate. And that was a statistically significant reduction in readmissions. We also demonstrated that all-cause hospital readmission was also statistically different, 2 in our telehealth arm and then 10 in the standard arm. We didn't see a difference in our emergency room utilization, and I think that the message is like people still need to come in and be evaluated. We don't have a triage, so they all go to emergency room, but there may be some more work to do there. And then a couple other interesting points was that the amount of clinic visits that they had within those first 10 days, so everyone's recommended to come back once if you're not doing some sort of home monitoring. So we had 20% of our telehealth women come in, but the standard outpatient care arm, only 65% came in, regardless of the recommendation, they should all come in. So we saw a statistical significant difference there, and we wanted to have a reduction in the intervention arm, but I just also want to point out that even when you're supposed to come in, they're not all coming in. And then also, how many people had a blood pressure reviewed within 10 days of delivery? So in our intervention arm, despite the fact they were not coming in, 94% of them had a blood pressure that was reviewed within that first 10 days, compared to even if they were coming in for a blood pressure check, only 60% had them reported in the medical record. And then the total amount of clinic visits prior to the 6-week postpartum visit was also statistically reduced in the telehealth intervention compared to the standard outpatient care, which is about 0.8 versus 1.6 clinic days or visits. So this last table here that I wanted to share with you is just outpatient hypertension-related outcomes just amongst the telehealth users, because we're not having blood pressure results on all the other patients because they're not coming in for those evaluations. But what I wanted to highlight was that, similar to the feasibility study, participants having the severe hypertension, as I defined, was 26% of our women, and it was happening 2 days from discharge. The patients who were requiring blood pressure treatment, again using the same threshold of 150/100, was 54% of our women, and that was happening about 2 days from discharge. And we had 64.5% of our women who needed some sort of antihypertensive medication over those 6-week postpartum period. And we initiated meds on 21% of people, and we increased the dosage of meds on 25% of our women. So how did they do with compliance? There's 2 different ways to look at this. In the immediate first 10 days, day 1 is a little bit low at 76%, but we remained over 80% compliant on all those first 10 days. And then through 6 weeks, you can see it gradually drops off. But even by week 6, where a lot of people have gone in for their 6-week postpartum visit, we clearly remained over 80% with follow-up those 6 weeks. So just a couple patient comments. This person felt empowered, informed, and safe. The nurses made them feel like they mattered, and the program saved them a lot of stress and grief, and they would recommend it to all women in their situation. And then this was actually from a staff member who recently emailed me, and they were like, by the way, I had a new baby girl, and my wife was in your program. I can't imagine how rough it would have been for her and the family if she wouldn't have been able to be on this remote monitoring and needed to go to clinic. Saying this experience was great just doesn't seem to give it justice, and thanks for what you do. We have performed a cost analysis of our study, and I'll just have to say, like, constantly the costs of this is going down, down, down. And so I think if I redid this cost analysis, it may even have better results. But what we really wanted to do is evaluate the cost effectiveness of telehealth blood pressure monitoring for postpartum women with hypertension disorders from the hospital's perspective. And you can see a couple figures here. So this is the incremental cost effectiveness ratio and the cost of telemedicine in general. And so you can see where that intersects here. So the average cost of telehealth per patient was $319, and it was found to be cost effective up to a cost of $423 per patient. We also looked at the cost of postpartum hypertension readmission. Again, the axes being quite similar. And you can see it intersects here. And what the results suggest was that telehealth monitoring remained cost effective down to an admission cost of $11,245. Our baseline estimate for our average cost of readmission was $14,400. And then the cost effectiveness threshold ratio by readmission rate. So that intersects up here. But what we found was that our readmission rate was cost effective down to a readmission rate of 2.9% with just our standard program. Again, I think that would even be lower now with just the differences in cost that the equipment may cost. And if we could make equipment cheaper, it would be even better. So to scale up, so our study demonstrated that we could effectively reduce readmissions, but it also showed that it was cost effective and cost saving. So I had mentioned the cost to the healthcare system early on, and we applied our data to that. So with a cost savings of $83 per patient and an estimated 330,000 pregnant women with hypertension in the U.S. per year, it could reduce healthcare costs in the U.S. by approximately $28 million. So I'm excited to say that now where I work, this has become the standard of care. So we did some community advisory work and tried to figure out, like, what should we call this? Because a lot of the women were like, do not call it telehealth, don't call it telemedicine, like, that's alien-like, like, what does that mean? So what they actually suggested we call it was Staying Healthy After Childbirth, a program to help new moms with high blood pressure. And they really wanted simple language for us to come and talk to them about it, and, you know, how do you appeal them? And once you really explain it to them, like, there's really not a woman that declines this type of program. So we take all comers with hypertension, and we talk to them about how and what they will do in our program. We've tried to really be culturally sensitive, geographically sensitive, and then just try to make this appealing for all people. And again, my hospital has made this a free program that we can provide it to all women in the postpartum period. So future directions is I really want to evaluate this in a more diverse populations, whether it's racially or geographically. I think rural places would be an extremely helpful place to offer this, and also there's a lot of small delivering hospitals that don't have the resources to provide this kind of care to women. And then I want to perform a definitive randomized controlled trial that would assess dissemination and implementation of this at multiple sites, state and nationwide. I also should just quickly give you a little blurb. I didn't talk about anything other than hypertension, but our tablet does screen for depression using the PHQ-9. We decided we'd implement that, you know, on week 4 and get people resources into care earlier if they needed it. But we asked them about their mood multiple times per week, kind of dovetailing off of the importance of having some sort of depression screening postpartum. And we're also looking at other things like telelactation, providing social services to people that like can't get into the healthcare system very easily. You can bring in social workers or other things that they would need. And so I think that really, like I said, sky's the limit with what you could do with this postpartum telehealth in the home. This is the team I currently have. It does take a team effort here. We have a research coordinator. We have actually 3 to 4 nurses that actually, it's really appealing to them to have these like small FTE jobs that they either complement with their other jobs or not. But I've trained them to really be experts just in this postpartum hypertension and how to take care of it, and that's all they do. And then I have a medical assistant at this point who does all the enrolling of all the patients. That's that, and at the very end I did throw in some CPT codes if people are interested. However, the bad news is that insurance is not paying for a lot of these yet, which we have to change the environment for. Happy to answer any questions.